Hey guys, this is Dr. Izrab with Integrative Kidney Solutions again, and today I'm going to be talking to you about the management of osteoporosis in chronic kidney disease patient. So I frequently get asked by my colleagues about management of osteoporosis in our mutual patients that I care for, especially patients with advanced kidney disease and those who are on dialysis. So I don't want to claim that I am an expert on osteoporosis, but I hope that this video will offer some guidance and some of my expertise in management of these patients, and also the review of the literature with the up-to-date information from the guidelines and the literature that is available out there. So before we talk about this, we know that WHO defined osteoporosis as a T-score of less or equal minus 2.5 or on a bone density test, or by the presence of a low trauma fracture with or without low T-score. So bone disease in kidney patient, however, is more complex actually, and is usually really classified according to the KDIGO guidelines according to bone turnover and mineralization and volume. Some patient may have normal bone turnover, and most of the patient have high bone turnover, and few patients have what we call low bone turnover, or what we call it adynamic bone disease. And many other patients, actually almost all our kidney patients with advanced kidney disease have vascular calcification. So all this is lumped together in one entity called CKD-MBD. So CKD, chronic kidney disease related mineral bone disease. We still don't know many things actually about the management of this entity, and what I might say today in this video may actually be irrelevant tomorrow. So for example, we still don't know what's the role of vitamin K. Yes, vitamin K in the management of kidney disease patient and vascular calcification. This is all evolving and exciting new research. Now, let me start by saying that almost all kidney patients and ESRD patients are at a higher fracture risk, period. In the past, it was thought that bone mineral density measurement is not accurate in patients with chronic kidney disease, but actually more recent data suggests that it is actually relevant, and it can project the risk for fracture in these patients. At this time, we don't know, however, how often CKD patients should get their bone density checked, how often they should get a DEXA scan. But it is suggested that those who are taking an anti-fracture treatment should be receiving their bone mineral density test every 1 to 2 years. So far, though, there are no primary skeletal or extraskeletal data on the use of anti-resorptive agents in CKD-MBD. And as you know, bisphosphonate are not recommended for patients with estimated GFR of less than 30 ml per minute because they're concerned that they accumulate in skeleton and also result in oversuppression and of bone remodeling. So what we know is denosumab or Prolia is, on the other hand, is not cleared by the kidneys. And while there is data that suggests that it does decrease fracture risk in CKD 1 to 3, there's no fracture risk data in advanced CKD or ESRD patient. However, there are data about improvement of bone mineral density in ESRD patients with the use of denosumab. One common problem that we encounter, in our practice, is that patients who receive denosumab, as you know, develop hypocalcemia, which lead to excessive rise of PTH, which complicate the management of CKD-MBD in dialysis patients. So I'm not really ruling it out, but I'm just saying that this complication can happen. There's also potential of use of osteoanabolic agent for patients with low bone turnover, or what we call adynamic bone disease. These agents, such as teriparatide, have been used in few observational studies in CKD and ESRD patients with limited success. So the future for this is still not clear, but we should stay tuned for these patients. These specific medications can cause hypotension and hypercalcemia. So how we should manage a patient with osteoporosis who is CKD or ESRD patient. So really the best management is a personalized approach that should consider first and most importantly controlled vitamin D, nutritional vitamin D deficiency, management of hyperphosphatemia, and management of hyperparathyroidism with active vitamin D agents and other agents in CKD patient. For those who have a T-score of less or equal minus 2.5 or a history of fracture, they should have an assessment of their bone turnover. It's a must to happen. And this requires really checking bone-specific alkaline phosphatase. If bone-specific alkaline phosphatase is higher than the median reference range, consider using an anti-resorptive agent. If it is below the lower limit of the reference range, consider using an anabolic agent. Probably in advanced CKD, but I would not use it right now in ESRD patient. Those who are between the lower limits of normal and the median, we don't really know what's the best treatment for those. The management for them is very complex, and they may require bone biopsy, which is very complex and is not available right now commercially and widely. So really what we recommend generally is the use of denosumab in advanced CKD patient and ESRD patient who require an anti-resorptive agent. So definitely no bisphosphonate. And this should be done and must be done after the first step is accomplished, and must be sure that the patient's calcium is normal or high normal, and their vitamin D, nutritional vitamin D, is corrected. And I ask you please to notify the nephrologist who's caring for your patient before you give the patient denosumab or Prolia. I hope this video was good and informative. For more information, please follow us on YouTube, on our YouTube channel, and sign up to our newsletter at www.inkidney.com.